Okay, so any questions from yesterday? I did have one person with a question on the board. They were asking about on slide 44, it says renin-angiotensin system causes sodium excretion. Can you please explain how? This is more referencing how it's regulating sodium excretion, right? So if the renin-angiotensin system, for instance, is increasing release of aldosterone coming from the adrenal glands, then what does that do to sodium excretion? Decreases it or increases it? Actually decrease sodium excretion because you're going to be holding on to more of that sodium, thus you hold on to more water. What will that increase the excretion of? Potassium, right? But if I inhibit this system, like if I were to give someone an ACE inhibitor, like what's an example ACE inhibitor? Lisinopril, ramipril, perindopril, trandopril, any of those prils, right? You could just basically mutter something like pril, and then I'd probably say, yeah, that's right. So any of those would be fine, and when you interrupt that system, you're interrupting aldosterone, and so thus you would see increased sodium excretion, more potassium being held on to, and thus you can see potassium levels rise as a result of that. Make sense? Hopefully. All right, so let us continue on. We were talking about calcium channel blockers. What do you think these drugs do? Awesome, you guys already know the mechanism. Right there with me. Anywho, we have several different types of calcium channels located within the body. We're mainly going to focus on the L-type calcium channels. Certainly we have types that are going to be found on places like the skeletal muscle. You're going to find calcium channels sort of all over. This is the main one I want to focus on here because this is going to be really important for not only the heart function, but also for the actual the vasculature, right? The actual blood vessels can be affected by this pretty directly. And you're going to find we have kind of two main categories here we're going to talk about. We'll have the dihydropyridines, or DHPs, and then we'll have the other two kind of get lumped into the non-dihydropyridine category, as we'll see in just a few moments here. And so let's kind of look to see what specifically the L-type calcium channels are going to be really responsible for. But as I mentioned, vascular smooth muscle, the cardiac myocytes, and then the actual cardiac nodal tissue is going to be affected here by these calcium channels. And normally when you think about calcium influx into a muscle, what do you normally think about it doing? What does that cause? Contraction typically, right? So presumably if I were to inhibit calcium influx into a muscle cell, what would happen? It would relax, right? So this is exactly what you're going to end up seeing with these medications here, is that by blocking calcium influx, you're going to cause relaxation of the muscle, you're going to cause slowing down of the heart, decreased contractility, all of these things you're going to expect to see based off of blocking these calcium channels. So have you covered the cardiac conduction cycle? Presumably, yes, I would imagine. So we'll talk about this more extensively in the next section of the class when we talk about the antiarrhythmics, because that's going to have much more direct effects on the actual the entire cycle itself in terms of blocking sodium influx and things like that. But here we're going to be focusing mainly on calcium, and so the two main places we're going to see this become really important is going to be for the actual nodal tissue. So the SA and the AV node will be affected by some of these calcium channel blockers, and the natural ventricular muscle is the other big place that we're going to see this being affected here. Okay, so when you're talking about the calcium channel blockers that affect the heart directly, you're going to expect to see decreased nodal activity, which leads to what? So if I decrease the activity in the nodal tissue, what does that do to, say, heart rate? It'll decrease it, right? So it's going to slow down the automaticity of those nodes. It's going to cause what to occur? Bradycardia, absolutely, right? So you can see heart rate drop down. So if I had someone with a really fast heartbeat, this may be a group of drugs that could be really good, right? If I had like a supraventricular tachycardia or something. In the ventricular muscle, by inhibiting calcium influx, what do you think that'll do to those muscle cells? They won't really contract as hard, right? Because there's less calcium coming in, so you're going to see that's going to be affecting, what do we call that? How hard the heart's beating. Contractility, right? So the contractility of the heart's going to go down, right? So what's another term for that? If you talk about the speed of the heart being chronotropy, what would be the contraction? Inotropy, right? So you're going to consider some of these calcium channel blockers to be negative inotropes, because that makes sense, because calcium's not coming in, that's blocking that. Yeah, negative inotrope is going to decrease contractility of that smooth muscle there, or the cardiac muscle. And again, looking at the SA and the AV nodes and the nodal tissue, remember you had those leaky sodium channels? That's what kind of sets the automaticity, how fast the sodium's coming in. But what causes the big spike up in electric potential? It's all calcium, right? So again, if I can block that, you're going to find that you slow down the actual automaticity of those nodes, and you're going to slow down the heart rate. Versus what causes this big plateau phase here in, say, the other non-nodal tissue, say the normal myocytes? it's all calcium, right? So if I block this, you're going to see that the actual force of contraction, that plateau is going to be shortened, that force of contraction is going to be much lessened, okay? Anyway, so these are kind of the clinical effects you're going to start to expect to see here. And this makes sense because normally what would happen during, say, the excitation phase is that when you have the sodium channels open up and allows all the sodium to flow in, that will then trigger those calcium channels to open. Calcium then flows into the cell, and that doesn't actually trigger off the muscle itself specifically, but what does it open up at that point? Sarcoplasmic reticulum, right? So it opens up kind of the calcium storage of the cell. It's going to open that up, and then will allow for the actin and myosin to come together. The sarcomeres contract unless you have your heartbeat, right? So that's what we're seeing here. By blocking this influx, a lot of that calcium that's in the sarcoplasmic reticulum will never come out, right? Or it'll come out at a much slower sort of rate. So because of that, that's how these are going to have kind of these big effects here. So looking at the calcium role in the vascular smooth muscle, normally what you see here, and again, if you're kind of comparing like skeletal muscle versus, say, smooth muscle, kind of which one has like kind of like slower, longer sort of contractions? Smooth muscle, right? So this is very dependent on calcium. So instead of worrying about like sodium coming in and triggering off those action potentials, here by blocking calcium, you basically will again have less calcium coming from the sarcoplasmic reticulum, and thus you're having less of this activity here. So overall, you're going to find that you have this relaxation effect that occurs because again, the actin and myosin are not going to want to bind to one another without that calcium, right? So looking at this, you're going to find that calcium channel blockers at therapeutic doses typically will decrease venous tone, which is handy because those are our capacitance vessels that will allow for more capacity. You're going to increase the diameter there and allow for more blood to be held in those sites there. However, we're going to find that typically they don't have any, they're ineffective at decreasing venous tone. The arterial tone is really what's going to be more effective. So just going to rewind 30 seconds and forget what I said. The arterial tone is really what's going to be more affected here with our calcium channel blockers on that vascular smooth muscle here. So as I mentioned, calcium channel blockers, they'll decrease afterload pretty significantly, but they don't have a good appreciable effect on preload. That'll become important a little bit later when we talk about things that may have more of a balanced effect between venous and arterial side dilation, but here we're going to find the calcium channel blockers specifically are going to act more on the arterial side. So really good for blood pressure, right, to help get that down. However, it may not be good for things like, say, CHF necessarily because it doesn't really do a whole lot in terms of preload, right? And typically CHF patients have what issue with preload? They have too much of it, right? Because they have a lot of backup because their left ventricle is not pumping so well, and thus they're going to have a lot of fluid buildup. So looking at calcium in the arterial blood vessels versus the myocytes, again, the myocardial cells really depend on that exogenous calcium coming in from those L-type channels there, and then it will trigger off that recirculating pool of calcium from that sarcoplasmic reticulum there. Versus the arterial blood vessels, they don't really have as much of that sarcoplasmic reticulum calcium buildup, so they're really just dependent on how much calcium is really coming in to the cell overall. And so you tend to find that these are going to be much more sensitive to the activity of the calcium channel blockers than myocardial cells. And we'll talk about the balance of activity between our dihydropyridines and the non-dihydropyridines in just a few moments. Get all into the details. Anyway, as I mentioned, when you're looking at your effects on the nodal tissue itself, typically what you're going to find, and this is a good thing to remember now, is that dihydropyridines as a group, and I'll talk about which drugs fall into that group there, don't have too much of an effect on the heart itself. Their job is to work on the blood vessels, to work on the arterial side of things, to decrease afterload, decrease blood pressure, right? The non-dihydropyridines are going to be much more specific to work on both the blood vessels and also the heart itself. So this is where you're going to see a lot more of that nodal tissue effect, where it's going to be slowing down with that inward current and decreasing that rate of recovery. So you're slowing down AV conduction, and it's going to ultimately slow down the heart rate. Okay, so kind of keep that distinction in mind. We'll talk about the individual agents in just a little bit. So what do we use these drugs for? Well, we can use them for angina, we can use them for hypertension. A lot of supraventricular arrhythmias will be treated. So again, if there's too much conduction from the atria down to the ventricles, you can slow down that transmittance of that signal using something like a calcium channel blocker potentially. We'll see this with cerebral ischemia, migraine prophylaxis. There's a lot of different things we can use calcium channel blockers for. We'll kind of figure out where to use each one of the agents and to seeing which one might be better suited for one thing versus another. So getting into it, let's go ahead and compare our different drugs here. So again, dihydropyridines themselves as a class, you're going to see they have really good effects on causing vasodilation. And again, on this chart here, I'm going to ask you a test question. Hey, on that one block, was that 4 pluses or 3 pluses? No, but the general flow of things, the general kind of tendencies here, I want you to notice. So looking at the dihydropyridines, you're going to notice they have a lot of effect on the vasodilation, so really good for blood pressure management. However, what are you going to notice about their suppression of cardiac contractility? Not great, right? Because they're not all that specific for acting on the myocytes themselves. Not really great at suppressing SA node automaticity, AV node. Not great from any of those standpoints, okay? However, one thing you could see is what happens when you dilate the vessel. Say TPR goes down pretty dramatically. What does the body do to compensate for that? Heart rate increases, absolutely. So think about these reflex mechanisms that occur here. So if you have a patient, I see this all the time. Say for instance, I have a patient who's on a bunch of different blood pressure medications and they decide they want to commit suicide, right? So they decide they're going to take all of their blood pressure medication. I don't know which one they took. Very frequently, by looking at the vital signs, they can kind of clue me into thinking what they may have been exposed to. So if they took a drug that affects both the myocytes and their arteries, you're going to find they will present bradycardic and hypotensive, right? Versus if I have someone who's taking a vasodilator, like a dihydropyridine, or their vessels are wide open, what do you think the heart rate's going to do in those situations? They're coming in super tachycardic, right? So that leads me to think, oh, wait a second, this might be a dihydropyridine calcium channel blocker versus something else, right? So just a little preview, kind of the things we'll be looking at in terms of what kind of cardiovascular effects we're expecting out of these medications here, okay? Now, for instance, if someone, say, took way too much of an ACE inhibitor, what would you expect to see? You could see hyperkalemia, all right, sure. What about the actual vital signs? What would you expect to see? Low blood pressure, high blood pressure? From an ACE inhibitor? Low blood pressure, right? Because again, they're antihypertensive, so you just would see low blood pressure, maybe a mild tachycardia, but did they have any direct effects on the heart? No, right? So again, kind of think about where these drugs are working at, and they can kind of guess what the sort of adverse effects you might see from that standpoint, right? So kind of the things I want you to start thinking about. On the other hand, with our non-dihydropyridines, so the two agents you're going to see fall into this category is going to be diltiazem and verapamil. They're going to be okay at causing vasodilation, so they're pretty good at that. They can still be used for blood pressure management, but what you're going to notice here, they're much stronger in terms of causing suppression of contractility, and they're going to be suppressing AV and SA node function here. So do you think a drug like this would be good for a patient with CHF? Why not? What's the problem with CHF? Poor LV function, right? The contractility is down because they've been remodeling that left ventricle. It's been overworked all this time. It's hypertrophied, it's thick, it's non-compliant. Do you think decreasing the contractility that ventricle is going to be a good idea? No, right? So again, you're starting to see where some of these drugs may be contraindicated in certain disease states based off their activities on the actual organs themselves, okay? So again, start to kind of think these things through. That's why it's so good to have a really good handle on the actual physiology, so that way we know when we add drugs onto the mix, how is that going to be affecting the system, right? Not just the direct effects, but also what are the downstream effects? What are the reflex mechanisms that come into play when you introduce these drugs? So starting off, let's look at diltiazem, which is going to be one of our non-dihydropyridines. This one's going to be, we have both IV and PO formulations that are available. Usually IV is going to be kind of reserved for those sort of acute, emergent sort of situations where you got to get the heart rate down sort of in a very fast sort of manner here. So if you hear of an SVT or supraventricular tachycardia, these tend to be pretty good IV agents for that to help manage that. But PO, we see them, people take it chronically, usually in sort of a sustained release sort of preparation. IR just means what? Immediate release, right? Could mean interventional radiology, but for our purposes, we're talking about drugs, right? So IR means immediate release. And so, again, we can see it used for angina. Why do you think it would be good for angina? So it could be a vasodilator, so that could be one thing, right? So it could increase some blood flow to the heart. What's the other big thing, though? Because remember, with angina, we're going to talk about this later, but it's an issue of demand versus supply, right? What do you think this does to oxygen demand by the heart? Decreases, right? Because again, you're slowing down the heart, contractility is going down. These can be used for that potential, right? So we'll talk about these as being good anti-anginal agents, good for hypertension, and then as I mentioned, a lot of supraventricular tachycardia. It's not really so great for ventricular arrhythmias, but supraventricular could be much better use there. And we'll actually talk about these later on in their use as antiarrhythmics. But let's focus on them more in terms of their kind of chronic use for things like hypertension. Now, other effects you might expect to see here. So if I'm causing vasodilation, certainly you can see things like peripheral flushing, right? So you see flushing, you see headache. Why do you think you see headache? all those vessels are opening up, causing pressure. Yeah, that's basically kind of how we see a lot of migraines develop there. So we see headache associated with that, hypotension, and then peripheral edema is going to be a big thing you see with these agents here. This will be more pronounced with the dihydropyridines. We'll see in a little bit, but certainly peripheral edema could be occurring here. And then we mentioned the negative inotropic effect, so you expect to see bradycardia, but you can see AV block. You really can see exacerbation of CHF, which you have to be really careful of because, again, decreased contractility there in the ventricle. Where is that fluid going to back up potentially? Back into the lungs, right? So you can see pulmonary edema develop from that, right? That's interesting. So again, we talked about smooth muscle being really dependent on that calcium coming in to cause contractions. Where else could that affect smooth muscle? Don't really ask that question, but the GI tract's going to be really at play here. So what did you expect to see if you were blocking calcium influx into the GI tract? Decreased motility, right? Leading to what? Constipation, right? So constipation is a big side effect from these medications as well. Is you have to be careful with that. And again, think about a patient who's on chronic pain meds, right? Maybe they're on opioids chronically. That's causing constipation. This can worsen that, right? So think about these interactions here. Yes, ma'am.
How does it cause diarrhea then?
It's one of those things where, so you guys know how like adverse effects actually get listed like in the drug monograph initially. So during clinical trials, they're giving it all these people here, and they report out any adverse effects they have, right? So if someone happens to have diarrhea while they're taking this medication in a clinical trial, they list it as an adverse effect. So even if it's something not really directly related to the drug, they still report it. So nausea, vomiting, diarrhea, guess what? It's been an adverse effect on every single drug we're looking at, mainly because someone probably had it during a clinical trial, so that just kind of gets carried forward. And so it's reasonable to say, okay, well, yeah, maybe someone's going to have a bad reaction to it and they'll have a little bit of diarrhea. Okay. But more commonly, what you're going to run into is the constipation. Physiologically, that makes sense based off the action of the drugs, right? So that's something I want you to kind of focus on there. Again, elevation in the liver function test, so just be wary of that. If you have pre-existing liver disease, this could be something that is exacerbated. And then you could see a little bit of the CNS effects here. Now, why do you think you'd see fatigue, drowsiness? Why do you think you'd see that? Decreased contractility, but decreased blood pressure, right? So that could lead to cerebral hypoperfusion potentially, right? So especially like orthostatic hypotension can develop there. That can lead them to get fatigued and dizzy, things like that. So think about that. You can see a little bit of gynecomastia. Now this one I don't know the full mechanism on. I'm not sure if anyone really has come up with a good one for that. And sexual dysfunction can occur. And remember, we said sexual dysfunction can occur with basically any of the antihypertensive classes, right? Especially the vasodilators tend to be a little bit more prominent with that. Okay. Some gingival hyperplasia, which is an interesting side effect. Anyone know how you manage that? Just good dental care usually helps to kind of, routine teeth brushing and things like that usually helps keep that gingival hyperplasia kind of at bay. And then potentially you could see some skin reactions, which is kind of not specific there. But contraindications to receiving diltiazem would be if you have any kind of advanced heart block, if you have hypotension already, this is just going to exacerbate that. And again, be careful of patients with heart failure because you could lead them into a heart failure exacerbation. Got to be careful with them. If they have existing liver disease, obviously GERD, this can worsen that because you're slowing down motility. These all will be relative contraindications. Does that mean I can't give it to them? Just means you want to think about it, right? You want to think pretty hard about it and see if there's an alternative agent which might be a better option. So this is big, right? So what effect is diltiazem going to have on other medications, right? So this is a pretty strong CYP3A4 inhibitor, okay? This is important because like what other kind of drugs might be substrates for CYP3A4 that we're talking about that a cardiac patient might also be on? Statins, right? So this is a big thing you want to consider. So it's a CYP3A4 inhibitor, so things like simvastatin, atorvastatin can be affected pretty significantly by this. You can see those myalgias and liver disease develop there. But again, lots of other drugs. And again, I'm not going to ask you on a specific interaction if we haven't really covered that drug before. So certainly I would know, hey, simvastatin, atorvastatin, those are definitely going to be substrates of CYP3A4. But we'll focus on carbamazepine and tacrolimus and stuff at later sections there. I'm just kind of listing them out just so you have an idea of kind of the drugs that are going to be affected by these inhibitors. But it also affects P-glycoprotein. Remember, what does that pump do? Some of the grapefruit juice affected too. Remember, it's an efflux pump, so normally it keeps, when it's working, it's keeping drugs out of the system. And so here, when you inhibit that, what does it do to the drug levels? It's going to increase it, right? So it's similar to the effects of CYP3A4, just through a different mechanism. Drug levels are going to go up, so just be aware of that. However, we'll talk about some pharmacodynamic interactions a little bit later on, but this is going to be synergistic if you include this with other cardiac active meds, right? So for instance, if I were to put someone on something like a beta blocker, right? We'll talk about beta blockers a little bit later, but beta blockers do what to heart rate? slow it down, right? So what did these do to heart rate? What does diltiazem? Slows it down. So guess what? If you do the two together, it's going to slow it down even more, right? So think about the pharmacodynamic interactions here. If I put this on with another antihypertensive, guess what the blood pressure is going to do? It's going to go down even further. That may be necessary for some patients. However, it may be problematic, right? It could be an adverse reaction if they get down too low. And again, just be aware of the fact that we're going to see this increase in half-life due to those CYP3A4 inhibitors here. Now, other CYP3A4 inhibitors can actually affect diltiazem as well, which is interesting. So not only is it a inhibitor of CYP3A4, but it's also a substrate, such that if you have another inhibitor on board, something like grapefruit juice, this could affect the half-life of diltiazem as well. Okay, so something to know. Okay, very similar to diltiazem, and in fact, I'm not going to really draw a lot of distinctions between them two. Between the two is going to be verapamil. Verapamil is going to be the other non-dihydropyridine you're going to see used pretty commonly. You notice here it's still available IV or PO. It's mostly available in a sustained release preparation orally, so that way it's kind of lasting throughout the day. And what do you notice about the indications? All the same, right? So again, you kind of think about these drugs kind of synonymously together. Again, maybe slightly different actions in terms of their effects on the heart, but for the most part, I think about them kind of in the same. If I don't have diltiazem available on the formulary, guess what? Verapamil probably is, right? And vice versa. So that's what you're going to typically see, and you kind of think about the two in your head. Again, very similar effects here in terms of side effects, in terms of contraindications. I'm not going to belabor these points here because we got too many slides to go through, but very, very similar in terms of their activity. Constipation is going to be a big thing you're going to see with that. CNS effects, sexual dysfunction, all the same. Okay. Again, same relative contraindications here. And also, this is going to be another CYP3A4 inhibitor. Okay. So just know that both of the non-dihydropyridines are CYP3A4 substrates, and they're also inhibitors of that system. So be aware of those interactions, right? So if I say someone comes in and say they're taking simvastatin, which one of these medications would be a relative contraindication add-on? If you see verapamil and diltiazem, that would be a good answer because of the CYP3A4 inhibition, right? Okay. So those are the two non-dihydropyridines. Now we get into the dihydropyridines, or DHPs, if you've ever seen them abbreviated like that. We have a couple here that fit into this category. They always end with pine, P-I-N-E, at the end of the name here. So you have like amlodipine, nifedipine, nicardipine. You also have felodipine, isradipine, and nisoldipine, and then there's also nimodipine. These are kind of the most common ones you're going to be running into. So the big difference between the non-dihydropyridines and the dihydropyridines is the fact that the dihydropyridines have relatively little effect, a little direct effect on the cardiac myocytes. Okay, they're mainly going to be working as arterial dilators. That's kind of the big difference there. So what do you think it's going to do maybe to the peripheral edema? It's going to be worse or better than the non-DHPs? Actually, it tends to be worse, right? What do you think it does with the constipation? It tends to be a little bit more specific there, and you can actually see that it tends to be a little bit worse, right? So, or at least a little bit more common, as you may see there. So that's just some of the things I want you to note that with that. We actually have some of these available IV, which is also really nice. We can give these as a continuous infusion to really kind of titrate the blood pressure to exactly where we want it to be. If you had a patient who came in with, say, hypertensive urgency or emergency, something like that, very, very helpful from that standpoint. Probably the most common one you're going to run into, though, is amlodipine. It's probably been kind of, it's like the simvastatin of the dihydropyridine calcium channel blockers. Nimodipine is actually kind of interesting. This one is used specifically for subarachnoid hemorrhage. What's interesting is those patients that have subarachnoid hemorrhages is they can have afterwards they can have cerebral vasospasm, which can kind of worsen their situation, can decrease oxygen flow, and we will actually give this to try to prevent that spasming from occurring there. And this will be important as well when we talk about other vasospasms, including causes of angina, right? We're talking about prinzmetal angina, and we'll talk about how this can be useful to treat that. Anyway, typically you want to avoid short-acting formulations because when you use really short-acting ones, they tend to bottom out the blood pressure very quickly, which can lead to a lot of orthostatic hypotension, falls, things like that. But you can, by using a long-acting formulation, you don't have as severe of an effect. And again, look, here you see that mainly the effects will be vasodilation, nothing to do in terms of suppressing cardiac contractility, very minimal effects here, and nothing really to speak of in terms of causing inhibition of the automaticity, okay? But mainly the vasodilation is a big thing.
I do apologize. Is it too hot or too warm in here? Everything good? Y'all feel the coolness? They're checking on the temperature.
Well, I'm here, so I always feel the coolness, right?
So everybody good. Why?
No wonder I am married. Anyway, so as I mentioned, you're going to see the vasodilation is kind of the hallmark of the dihydropyridines here. So peripheral edema is going to be particularly bad here. You can see some dyspnea and wheezing. Some of that is related to some of the pulmonary congestion that can develop there. And then that rebound tachycardia is the big thing, okay? So again, if I had someone who had too much amlodipine on board, you'd expect them to see low blood pressure, but tachycardia as a result of that, right? It's all part of that compensatory sort of mechanism there, okay? Mentioned GI effects, you're going to see it being prominent here with constipation being a big thing. Similar CNS effects with that cerebral hypoperfusion can develop there. And then gynecomastia tends to be a little bit worse with something like nifedipine versus diltiazem, so that would be one thing to know. What other medication do we mention also causes gynecomastia? Yeah, spironolactone, right? So your aldosterone antagonist can do that potentially. Again. If you had severe aortic stenosis, why do you think this would be a problem? So think about if you're looking at, so imagine you have the aorta here, so say it's kind of looping over, and say there's some bit of constriction, right? So you have some degree of stenosis. What happens if I dilate all these blood vessels here? Now they're all wide open. You're not really going to be able to perfuse those organs very well, right? So that's one of those things where you want to be really careful in those patients there, because you'd find really poor perfusion of those organs because the vessel just dilated and you can't really get enough blood flow coming through the aorta there. So that's one thing to consider. And then also unstable angina or recent MI. Why do you think that would be a contraindication to receiving a dihydropyridine? Well, think about, remember we said angina is a result of oxygen supply and demand. So if I were to give them a dilator, a vasodilator, and I'm causing the heart rate to do what? To go up. What does that do to oxygen demand by the heart? It goes up as well, right? So again, think about these kind of mechanisms. Think about some of these disease processes and think, okay, well, how is this drug going to affect that? Now, on the flip side of it, we noticed that unstable angina, recent MI, was not a contraindication to the non-dihydropyridines. Why was that? Because what did those do to oxygen demand by the heart? Decreased it, right? Because again, they're directly negative inotropy, negative chronotropy, so it actually decreases demand of oxygen by the heart, right? So again, these things make sense if you know the mechanism and know specifically where they're working at in the body. Anyway, so again, you'll note that the dihydropyridines, they are CYP3A4 substrates, but they do not inhibit CYP3A4 themselves. So that's kind of the big difference between the non-dihydropyridines and dihydropyridines. The dihydropyridines do not inhibit CYP3A4, but you will find other drugs that can affect 3A4 may have an effect on these drugs here. So if I added grapefruit juice on top of the amlodipine, you'd see increased levels of amlodipine. The half-life would get longer, more likely to see, low blood pressure, things like that. Okay. And a lot of the interaction you're going to run into are going to be more pharmacodynamic, meaning synergistic effects with other blood pressure lowering medications, things like that. Okay. Anyways, as I mentioned, CYP3A4 inhibitors will increase the half-life, so just be aware of that interaction. Okay, so any questions on the calcium channel blockers? Now again, we're covering like a ton of drugs. We're going to focus more on how we're using them a little bit later on. So what's nice with this section here is that when we get into talking about things like angina, talking about CHF, we've already covered all the drugs for it essentially. We just got to talk about how we're going to use them specifically here. So it may seem like we have a ton of more stuff to go through, and we do. However, you're going to see a lot of this is going to be repeated information. Like, a lot of it's going to be like, okay, well, we remember how we said this about beta blockers? Here's how it's important now to this particular disease state. So just kind of keep that in the back of your mind. What do beta blockers do? Block beta receptors. Which beta receptors do they block? Beta 1 and beta 2. Depends. It depends on the drug you're dealing with, right? We're talking about selectivity and that being an issue here, right? Beta 1 primarily, where is that found? In the heart. Good. So if I block beta receptors in the heart, what does that do? Slows down. What does it do to heart rate? Slows it down. What does it do to contractility? We'll decrease it as well to some degree, right? How about if I, so there's beta 1 receptors, how about beta 2? Where do we find those? In the lungs. So if I block beta receptors in the lungs, what does that cause? You can see bronchoconstriction, right? Potentially, or at least you're preventing relaxation from occurring, right? What about in the blood vessels? What does that normally do? Remember, we still have beta 2 receptors on the blood vessels. When those are activated, what do? They dilate too, right? The beta 2 receptors do the same thing, and the lungs are on the vessels here. However, what's also a competing factor on the blood vessels that can be affected by things like norepinephrine and epinephrine? What other types of receptors? Alpha 1, right? Alpha 1 is the other big thing there, and alpha 1 causes what? Constriction, right? So again, there's kind of a delicate balance there between the beta 2 effects, which are vasodilatory, and the alpha-1 effects, which are vasoconstrictive, right? And that makes sense because when you're in a fight or flight response, you got to be able to shunt blood around appropriately to the organs that need it, right? So for instance, if I'm running away from something, do I need to really perfuse my GI tract very well? Not really, right? It's kind of a secondary concern, right? How about my kidneys? Not so much, right? You know, that can take a hit for a while. I want to keep blood volume up anyway. So these are things you want to consider. That's why there's that delicate balance between the two there. We'll talk about some other clinical implications for that. Anywho, so point being here is that when you are blocking this competitive blockade of cardiac beta-1 receptors, you're going to find cardiac output's going to go down. You may see somewhat of a reflexive sort of increase in total peripheral resistance, which sounds like this would be bad as an antihypertensive, but we'll talk about some of the long-term effects you can see with these, how we do use these for long-term control of blood pressure, as we're going to see here. You can see some impaired exercise tolerance. What do you think that is? Yeah, so imagine if you need to like go run a lap or something like that, and then it's always like the quintessential like PE teacher thing, like go run a lap, right? If you're slowing down heart rate, if you're blocking those beta receptors, normally your fight or flight response would say, okay, well, let's go ahead and kick up the heart rate, so that way we can perfuse the skeletal muscle. If I'm blocking those receptors, you're not going to be able to really respond that well. So if you have like a young, relatively healthy patient who's taking a beta blocker, that can cause, that can impair their exercise tolerance. We're not going to be able to kind of meet the demands of the body. What if I had someone, though, that had really kind of poor contractility? Maybe they have CHF, maybe they had angina, things like that. What do you think a beta blocker would do in terms of their exercise tolerance? It actually improves it, as you're going to find. So like specifically in the case of angina, by decreasing oxygen demand by the heart, they can kind of walk for longer before they start to tucker out, right? Before their chest pain starts to come back. Or if they have CHF, they can potentially walk around for longer before that decreased contractility really is going to be a big problem for them. We'll talk about why that is a little bit later on. But just know that depending on the disease state, how healthy the person is, this may actually improve their ability to get around potentially, right? Anywho, we're going to see here that also by blockading these beta-1 receptors, that will actually decrease renin release. So this is a big reason why this helps for blood pressure management, is because decreasing renin also decreases what else? Angiotensin II production, right? So this could actually be synergistic with an ACE inhibitor if you think about it. By combining the two together, you're going to get better suppression of that angiotensin system. Right? It could be beneficial things here. And as I mentioned, by blockading the beta-2 receptors, you will find that you may be able to block that bronchial smooth muscle relaxation. So it could either induce bronchospasm in someone with asthma, or imagine, how do we treat an asthma exacerbation? Anyone know? Yeah, albuterol, which is what kind of drug? The beta-2 agonist, right? So this will potentially blunt the effects of the drug itself, so that thus your albuterol may not work as well as it would otherwise, because you're basically blocking up those receptors. So again, little things to start thinking through. What else can we see? Well, some of these presynaptic beta-2 receptors, by activating them, you can actually start to shut down norepinephrine release. What do you think that does in terms of cardiovascular effects? I think it does to blood pressure. Less norepi means less alpha-1 activation, means decreases in blood pressure. What does that do to heart rate? Slow it down as well, right? So we'll talk about some other centrally acting drugs, but this is one ancillary benefit here with beta-2 active blockade here. And then also some the CNS effects. You're going to find that by decreasing sympathetic nervous system activity overall, we can find a couple of different interesting things here. One thing to be concerned with is how lipid soluble the beta blocker is, and the more lipid soluble it is, the better it can get into the CNS, and that can actually lead to depression. In some cases, it can actually lead to things like abnormal dreams and nightmares, and this is one of those things you got to be careful of in using in elderly patients, especially if they have like concomitant dementia and things like that. And then also, this can either induce migraine headaches, but we're going to find as well later on in the neuro section next semester that this actually can be useful for preventing migraines. So it's one of those kind of odd things where like calcium channel blockers and beta blockers, they can all induce migraines, but they actually can be used selectively to actually prevent migraines as well, which is kind of oxymoronic, but it does work out, as you'll see. And then overall, it's going to help with this baroreceptor reflex response. When I say that, what does that mean? Yeah, so remember how like your body kind of gets used to things over time. So if you're chronically hypertensive and you're, say, living at, say, 160 over 100, those baroreceptors normally would say, hey, there's too much pressure here, and they would do things to try to get the pressure back down. But if you just live at that pressure for long periods of time, what happens to those baroreceptors? Yeah, they just say, oh, this is just normal now, right? So just like when you get older, like, so some of you don't know this, but once you pass age of 30, things just start breaking on you all the time, and you're like, okay, this is just life now, I guess. I just have to, this is just a new phase, I guess. But so enjoy your youth while you still have it. Anyway, so Point being though is those baroreceptors, they get kind of reset to be like, this is just normal now, right? So if you try to lower that blood pressure, how does the body respond? Yeah, it says there's not enough blood pressure here, right? I'm used to living at 160 over 100. You're trying to get me down to normal? You're normal? I don't think so. My definition of normal is very different now. So it tries to raise that blood pressure back up through the renin-angiotensin system, the sympathetic nervous system, and all these things here. But by chronically helping to lower that pressure, you're going to be able to help kind of reset that baroreceptor reflex, right? So that's really one of the chronic things you're going to see with these beta blockers. So some of the differences in the beta blockers we're going to run into. We'll talk about a few different generations of beta blockers in terms of their activity. We're going to see that selectivity is going to be a big thing here. When we talk about selectivity, there's going to be non-selective beta blockers that affect beta 1 and beta 2 equally. There's going to be beta 1 selective agents, and those are only going to mainly block beta 1 receptors. Now, what have I said about selectivity before? Yeah, it's all relative. So if I have enough of the drug around, you're going to find that you can still have those bleed over effects. You can still have some degree of beta 2 blockade if I have a high enough dose of a selective beta blocker. And we'll talk about which ones those are in a moment. But other things to consider, does it undergo hepatic metabolism? Some of these are more renally eliminated. So you have to think about, do I have poor renal function in a patient? Are they not going to clear the drug as well? Or they may be not clearing it from the liver as well because their liver function is going down. These are things you want to think about. And then also, in some cases as well, you have what they call intrinsic sympathomimetic activity. And so this gets a little bit more complicated in terms of some beta blockers actually having a little bit of partial agonist activity at a beta receptor. We'll talk about which ones those are in a little bit. Clinically, this doesn't come up as frequently, but just be aware that this can be somewhat useful for patients with asthma to have a little bit of that stimulation there. Heart failure, that bradycardia, we'll see how that can be somewhat beneficial. Okay, other things. We talk about membrane stabilizing activity. Some of the beta blockers actually can be used, just by their nature, they're antiarrhythmics, right? So again, if I had a supraventricular tachycardia, beta blockers can be used to slow down the heart rate, right? However, some of them actually can have what we call membrane stabilizing effects and actually can help with their antiarrhythmic activity. By stabilizing things like the ventricles that may be aggravated and are sending off these kind of aberrant signals, you can kind of slow that down and hopefully kind of reset things and hopefully prevent arrhythmias. That's one additional benefit we'll see with some of these. And then some of them, with especially the third generation we'll talk about, tend to have other ancillary effects, which we're going to get into when we talk about the individual agents in just a moment. So looking at these, the non-selective beta blockers, here's our first generation agents. They will block both beta 1 and beta 2, very similar to one another. Okay. The main thing I want you to know is if you see something that comes off as like really high or something really notable, then those are maybe are key things you want to key in on a little bit, right? So for instance, with say for instance propranolol, really high lipid solubility. So if I were to say, you had a test question with an elderly patient and they're like, oh yeah, they're having all these new nightmares and they're just waking up and they just have no idea where they are. What medication can cause this? Well, a beta blocker could certainly do that. One with high lipid solubility would be more likely to cause that, right? Those are things you want to think about. If it has RE, it just means renally eliminated. If it has HM, it just means hepatically metabolized. I'm not going to probably get so in the weeds on that necessarily to quiz you specifically, just because there's so many beta blockers out there. But certainly if it has like good membrane stabilizing effect, if it has high ISA, those are things you want to kind of key on a little bit there. Okay. Now, what do you kind of notice about the naming convention here? So yeah, so you're going to see OLOL on the ends of those, right? So it's like OLOL. Funny joke. No. Yeah, you'll see LOL. So you always know a beta blocker when you see one. The other thing to note, and this is kind of a handy rule of thumb that I will tell students, and some benefits, some not so much. But if it starts with an N through the letter Z, typically it's going to be a first generation non-selective beta blocker. So like Nadolol, propranolol, Sotalol, those are all going to be non-selective beta blockers. Letters N through letter Z, if it starts with one of those, typically it's a non-selective beta blocker. Okay, one thing to know. Sotalol is kind of interesting. We'll talk about this one later in the antiarrhythmic section. It's actually blocks some potassium channels, and is useful as a antiarrhythmic in the ventricles. We'll talk about that more specifically there. But again, just know N through Z, typically non-selective beta blockers. Next off, we have our selective beta blockers. Oh yes, I'm sorry.
Did you say membrane stabilizing like the ventricles?
That can be somewhat useful for helping kind of stabilize the membranes to prevent ventricular arrhythmia from occurring. Yeah. Next, we have our selective beta 1 blockers. So here, again, they're going to be losing that beta 2 activity, so they're not going to be blocking the beta 2 receptors, but primarily focusing just on beta 1, right? So who might this be good for? Yeah, like an asthmatic patient or reactive airway disease is going to be a better option for those patients there. So A through M is typically going to be a second generation selective beta blocker. There are exceptions to this rule. We'll talk about those on the next slide when we get to the third generation, but typically A through M for the most part is going to be your beta-1 selective agents. So we have acebutolol, atenolol, bisoprolol. Esmolol is kind of an interesting one. It's called Brevibloc. This one is used IV only, and it's a very, very short half-life. It's really beneficial because if you have a patient who's hypertensive or they have a tachyarrhythmia, you can actually give this as a continuous infusion. And because the half-life is so short, I can kind of titrate my dose very specifically to get down to the right exact blood pressure that I'm looking for, which is handy there. Metoprolol is another very common one you're going to see there. There's Lopressor, there's Toprol. We'll look at some differences there in a little bit. But these are the main ones you're going to run into. Now the third generation, I said this is where the rule kind of falls down a little bit because your third generations don't follow that same naming convention. So these ones you just need to know. You have things like Cardiology, which we saw back in the ophthalmology section for glaucoma, right? Carvedilol, labetalol, and then betaxolol. This is another ophthalmic one. So these are the two big ones I want you to focus on in terms of systemic use. And these are ones you're going to see much more commonly for things like CHF. You're going to see them for blood pressure management pretty commonly there. So what are the things that kind of delineate the third generation from the rest of them? Another question?
Which one?
Oh, I'm sorry, carvedilol and labetalol, right? Because the other two we saw back in ophthalmology. Yeah, so focus on these two here, carvedilol and labetalol. I probably should be more specific and just say focus on these two, and then you just have to remember where my mouse cursor was going. Just remember this one particular fact here, and then, yeah. Anyway, so what are some additional beneficial effects from these third generation? What kind of sets them apart from the non-specific and the beta-1 selective agents? Here you can see carvedilol has some alpha-1 blockade, right? What does that do to blood pressure? It's going to decrease, right? Because normally alpha-1 activation causes constriction, so it'll decrease blood pressure a little bit better. Also has some antioxidant, anti-proliferative activity there, so it could be protective in some cases. And in fact, when we talk about CHF and we talk about approved beta blockers that actually decrease mortality, this will be one of those, right? So carvedilol will be a common one you see there. Labetalol, this one has some alpha-1 blockade, which we mentioned will lower blood pressure. Actually has some beta-2 agonism. So what would that do to blood pressure? That would lower it as well, because remember we said activating beta-2 receptors is going to be vasodilatory, right? It's going to relax that smooth muscle, just like it does in the lungs. It'll do the same thing on the blood vessels. So again, this is really handy as an agent used to manage blood pressure. Sometimes you'll see it used orally chronically, but we use this in the hospital all the time as sort of a PRN, sort of quick-acting medication to get the blood pressure under control. If you come in and you're saying, oh, my vision's all blurry and your blood pressure's like 200 over 110, like we can give you an IV dose of labetalol and get that down pretty quickly there. Not only will it get heart rate down, but the blood pressure also is going to be a big thing that will be affected here as well. Okay, so those are kind of the things that set these apart as a third generation versus your selective beta-1 agents. They're only working on beta-1 receptors. Okay. So what do we use the beta blockers for? We actually use them for a ton of different things here, certainly hypertension. Now, we're going to hear this is not going to be first line for management of hypertension. Other agents we've already talked about, things like your thiazide diuretics, things like your ACE inhibitors, those are going to be more first line, and we'll talk about hypertension management towards the end of the section here. However, you're going to find that this is going to work better in patients who maybe have kind of like a high resting sympathetic sort of activity here. However, we don't like to use it in young patients, even though it's pretty effective. Oftentimes, you're going to see a lot of complaints of fatigue and exercise intolerance. So because of that, they're a really active younger person. This is not going to be a great drug for them from that standpoint, even though it works really well. It may not be that great, but this is useful as an add-on agent. Or you may find there's a lot of other disease states that necessitate the patient being on a beta blocker, so you're just going to get that additional antihypertensive effects anyway. So if you had a heart attack, right, you need to be on a beta blocker, right? If you have CHF, there's certain beta blockers you need to be on, etc., such that you're going to be on them anyway, right? So it's one thing we'll see in a little bit. So looking at the mechanisms, right, why do they cause these effects here? So these are some graphs that kind of demonstrate the effects we're going to be looking at. So we have MAP here, right? What does that stand for? Okay, so we're looking at the mean arterial pressure. We're going to look at cardiac output, and then our TPR. Okay, so what's interesting when you're looking at this is with causing direct beta-1 inhibition, you're going to see there's kind of some direct compensatory effects that occur here. So looking at mean arterial pressure, you're going to notice that even though I start a beta blocker right off the bat, what do you notice happens with cardiac output? It'll decrease pretty immediately, right? Which makes sense because I'm blocking beta-1 receptors. Contractility is going to go down, inotropy is going to go down. Makes sense that cardiac output goes down. Now, what is the reflex response to that? Increase in TPR, right? So this is where you see this compensatory increase in TPR to account for that. So even though cardiac output's down, the blood vessels are constricting in response to that, and so thus what happens to your overall MAP? It doesn't really move a whole lot, right? However, what happens is with more chronic usage, what you're going to find is over time, you're going to be decreasing the angiotensin II production, you're going to be decreasing norepinephrine release, and you're also altering that baroreceptor reflex. What do you then notice over the long term? TPR is going to go, cardiac output will stay low, TPR eventually goes back down, and then overall your MAP does what? It's going to stay low as well. So again, this is really good for chronic management. Again, not first line, we have other agents for that, but useful as an add-on potentially, okay? Other indications, we talked about glaucoma already. It helps to decrease production of the aqueous humor there. And then for migraine prophylaxis, this one's kind of interesting because, like we said, what causes a migraine? Well, frequently it's that vasodilation that occurs there. It increases that pressure, activates that trigeminal nerve, and you see a lot of that pain associated with that. Well, what if I gave something that helped prevent, say, some of that variation there in terms of the dilation or the constriction of the vessels? By giving low-dose beta blockers, they can actually help to prevent some of that from occurring and prevent migraines. Don't get too hung up on that. We'll talk much more about it in the migraine section next semester, but just note that is one thing we may use it for. Hyperthyroidism, so we can use it for this as well. What are the symptoms of hyperthyroidism? Palpitations, so tachycardia. What happens to their blood pressure? Increase. What happens to they're sweating a bunch, their metabolism's up, all these things. Beta blockers can help to reduce a lot of those effects there, right? So it can help them with the tachycardia, the tremor, the anxiety that they're feeling. Because again, it's kind of like they're in a very hypersympathetic state. This is going to blunt a lot of those effects there, right? So you're going to see potentially increases in blood pressure, and some of that may be related to some of the beta-2 blockade effects there. So it's one thing you might want to know. However, one of the interesting things as well, and this is where propranolol gets used quite frequently, is it helps prevent the conversion of T4 to T3. We'll talk more about that later on in the endo section, I think next semester. But which one's more active, T4 or T3? T3 is more active, so we can prevent it from being converted to the active form. That can help to reduce some of those symptoms there. Okay, this is good for angina. As we mentioned, it is useful for helping to decrease oxygen demand by the heart, so that can be very useful. We'll talk more about that specifically later on. However, you want to be sure to avoid those that have any of that intrinsic sympathomimetic activity, because that can actually stimulate those receptors and may actually lead to worsening angina. So those you would want to avoid those patients there. Okay. But when you have angina, usually the thing that is rate limiting in terms of your exercise or getting around is going to be that time to chest pain, right? And so by giving a beta blocker and decreasing the oxygen demand, they can get around a lot better. So frequently we'll say, well, how far can you walk before you start to have chest pain? Instead of getting to the door, maybe they can get to the elevator, right? So those are the kind of increases in exercise tolerance we're talking about. Other things, we will use this in acute myocardial infarction. So depending on how the patient is presenting, if they're already bradycardic, do you think we give them a beta blocker? No, but generally once they get stabilized, if they're not bradycardic, they want to go ahead and get them started on a beta blocker. And this is mainly due to the fact that it will decrease oxygen demand by the heart, and there's proven mortality benefits. And so we'll go ahead and get them started on a beta blocker in a lot of those cases there. And then, as I mentioned, SVTs, or supraventricular tachycardias, are going to be another place where beta blockers are going to be very useful, mainly by blocking the AV nodes and slowing down the transmission. Okay. Now, panic attacks. Why do you think this would be useful for acute panic attacks? Again, think about the symptoms of when you're panicked, right? So you're sweating, you're tachycardic, you're anxious. Like, this is blocking a lot of those effects caused by norepinephrine and epinephrine. So by doing that, you can help to calm. You may still feel really stressed out, but however, those physical manifestations are going to be improved, right? So that's kind of the benefits of using a beta blocker here. We can also end up using it for performance anxiety, right? So, for instance, if you had to go and give a big speech, how many of you are like really good at public speaking? You are? You want to come up here? All right, let's do it. All right, so Remy might not benefit from the use of a beta blocker. However, if one of the rest of you who are not great public speakers yet, well, maybe one day, were to come up here, you'd probably be in a pretty stressed sort of state, right? You'd be very worried, you'd be nervous, you'd be tremulous. By giving a beta blocker, you can blunt a lot of those effects, right? It kind of helps not necessarily get rid of that stress and anxiety, but it helps to decrease the physical manifestations such that you appear more calm, and thus you can give a better speech, or you can play music or do whatever you need to do there, right? Just to give you a bit of a kind of funny anecdote before I give you a break. So when I was in school, we had this class called pharmacotherapy, and basically at my campus there's 50 of us, and we'd be sitting in the big auditorium, and we'd have our facilitator down on the floor, and basically we had gone through this process where we'd worked up a case, we'd done a patient interview, and we all had to come up with a plan, right? It had to be evidence-based medicine, we had to look at the guidelines and studies and all that stuff, and so you got called on at random to stand up there, answer questions from the facilitator, who's often the expert in the field. So you'd have like a cardiology pharmacist, or you'd have someone working in the ER, whatever the case may be. They would ask you questions, you have to defend your plan, right? It was very kind of nerve-wracking. It was because you had no idea when you're getting called on, and you had to really know your studies. You had to be able to back it up. It's like, well, this study is looking at these kind of patients, blah, blah, blah. Anyway, so needless to say, back in the day, I was not very good at public speaking, because I hadn't done it a whole lot, and some say I'm still not good at it, but extremely nervous whenever this would come up. And however, some of my classmates, guess what they were using to help them out? They were using beta blockers. So when they got called on, they would stand up. They would not appear quite so nervous. Their voice wouldn't be all quavering, and they would not be sweating profusely. And thus, they would give that air of confidence, and they could perform a little bit better. Now, this actually directly impacted their grade because they did better, and I was like, this is bogus. They're using performance-enhancing drugs. I'm sitting over here sweating, pile of sweat behind me, and just I can't even talk straight. Bogus. But I never saw it drugs, right? So don't do drugs, right? It's not worth it in the long run. Anywho, but you can see how those effects could be very beneficial for things like public performances and things like that. Anywho, so other things we can see this used for: congestive heart failure. There's very specific ones we're going to use here. Normally we mentioned that. What does this do to contractility typically? What do beta blockers do? It would decrease it. So you would think like, wow, this can actually put someone into a cardiac or a CHF exacerbation, and you're absolutely right, it can. But by starting at really low doses and gently titrating up, there's a few that have been approved for use in CHF. We'll talk much more about this later on and talk about how some of the monitoring precautions you need to do, but you do see mortality benefits in those patients there. And again, normally you're going to expect to see decrease in cardiac output, increase in TPR, increase in heart rate. However, by giving them kind of chronic beta blockers, you're kind of giving the ventricles more time to fill, they're increasing the efficiency, and thus you can end up finding that the cardiac output actually improves on beta blockers. Heart rate goes down, TPR goes down, so overall it has good benefits for them, including those mortality benefits as I mentioned. So those are the clinical indications, common places we're going to see beta blockers being used. Let's do 10 minutes and we'll come back and get into the adverse effects of those. I have a question here. It says, can we have BB for PD days if you go to a medical professional and they decide that you are a good candidate and they prescribe it for you? We can't stop that, right? It's your own medical business is all I'm going to say. Some people use other substances to try to help them out for PD days. Does not go as well, right? So follow the advice of medical professionals, what I always recommend. Anywho, any questions from the first half? All right, so continuing on, we talked about the indications for beta blockers, several different things we could try it for. Getting to the adverse effects, these are going to be pretty numerous as we'll see here. So we mentioned the bronchoconstriction, and this is going to be more prominent with which group? The non-selective, those first-generation agents there. Now, a common misnomer is that people think the third generations also are beta-selective, beta-1 selective. They're not really, right? So you could still potentially see asthma exacerbations with labetalol, with potentially with carvedilol. However, labetalol is a little interesting because it does have a little bit of beta-2 activation, so that one may be less of an issue. However, just in general, just note that your non-selective agents are more likely to induce this. Doesn't mean you give it to an asthmatic and all of a sudden they're going to have bronchospasm. It just depends if they have, if they already would have had a trigger for their bronchospasm occur in the first place, and it could just reduce the efficacy of their beta-2 agonists, actually reverse that. So it's kind of the things we think about there. And a lot of COPD patients also have a degree of bronchospasm additionally, so that could be another patient group you want to be careful with. Now again, less likely to occur with a beta-1 selective agent, so if you can use one of those, right, and we use the mnemonic, the A through M, so metoprolol, atenolol, one of those would be a little bit safer in those patients, okay? So we mentioned you're also going to see these cardiodepressive sort of actions here, and so again, that's related to the negative inotropy, the negative chronotropy. So again, if they're already bradycardic to begin with, this is just going to exacerbate that potentially, and can induce things like first through third degree heart block potentially. So this one's a little interesting. So you can see disturbed glucose metabolism, and it actually can manifest two different ways. So when I say type 1 versus type 2, I'm mainly referring to patients who are diabetics, right? So type 1 diabetes, what's their main sort of pathological problem? they just don't produce any insulin, right? So again, they've had an autoimmune reaction that's basically destroyed those beta cells such that they cannot produce any insulin. With a type 2 diabetic patient, what's their issue? Insulin resistance, right? They could be insulinopenic after a long time, but usually it's going to be more related to insulin resistance overall. And so what's interesting here is that when you have a type 1 diabetic patient, right? So for instance, they get hypoglycemic. Normally what happens, normally a good stress response here is that you're going to see things like glucagon get released, you're going to see things like epinephrine get released, and that causes that glycogenolysis and eventual gluconeogenesis to occur to raise blood sugar, right? However, if you have a beta blocker on board and they're blocking beta receptors on the liver, guess what happens? Less glycogenolysis occurs, and what could happen? Decrease in new glucose production, and thus hypoglycemia, right? And how does hypoglycemia manifest? Confusion, irritability, tremulousness, sweating, right? I call it the hangry reaction, right? You get hypoglycemic. Most people probably felt hangry before. It's kind of like what it is. But altered mental status, seizures potentially if it gets very severe, right? So those are things you want to think about. So beta blockers can inhibit that production of new glucose for them, right? So they can see hypoglycemia being a big problem here. On the other hand, though, with type 2 diabetic patients, hyperglycemia can be more of an issue. What's interesting is if you block these beta receptors, you can see decreased insulin production or decreased insulin release into the bloodstream, and less insulin is coming out of the pancreas. What does that do to overall blood sugar levels? Should go up, right? Because you're shuttling less of that glucose into the cells themselves. And so this can make it really difficult to control those symptoms there. And then this is the other big thing to note is that the beta blockers I mentioned, when you're hypoglycemic, you can get tremulous and you can get sweaty and irritable. What did we mention that you could use beta blockers for? To treat those effects of that sympathetic nervous system reaction. So you can actually block or mask the effects of hypoglycemia with a beta blocker such that patients don't know that they're hypoglycemic until they're about ready to pass out. Okay, so this is one thing you want to know with those patients, that if they're hypoglycemic, you may not see those symptoms. Okay, good thing to know about the beta blockers. So other things we can find here, potentially you can see impaired peripheral circulation, which can worsen things like Raynaud's phenomenon, where they have kind of this kind of cold extremities due to impaired circulation. So that would be a relative contraindication here. But also skeletal muscle fatigue, because again, you're not maybe getting enough blood flow to the muscles there, and that peripheral artery disease can be worsened potentially. Okay, and then another thing to watch out for is sudden withdrawal syndromes. You want to avoid stopping these drugs cold turkey for patients, especially if they've had previous MI or that risk for developing MI, mainly because when you're chronically blocking the beta receptors, what do those receptors do in response to that? They upregulate, right? So they're more numerous, such that when you take away the beta blocker, all of a sudden, what happens to all those receptors? They all get activated at once, and then guess what happens? Cardiac output's going to go up, heart rate's going to go up, contractility's up, and they can see the oxygen demand goes up pretty precipitously as well, such that you can induce MI potentially in those patients. Okay, so again, this is one of those medications where you want to slowly wean off of it as opposed to just stopping a cold turkey. You don't get the same effect with the calcium channel blockers, because if once you remove that, the calcium channels just start to operate normally again. Okay, so that's kind of one of the big differences between those two, is that you don't have to worry about the same kind of weaning phenomenon as you do with the beta blockers. Other adverse effects, the CNS effects can be big here. So you see this more frequently with the high lipid solubility agents. So I always think about propranolol or Andorol being a very common one to do that. So high lipid solubility is going to get into the CNS, can cause depression, can cause nightmares and like really vivid dreams and hallucinations. And sometimes it's really difficult to tell. Like, is it elderly patients' dementia getting worse, or is it something else going on? Is it drug intoxication? Is it just an adverse effect? Sometimes it's really hard to say. You guys ever heard the term sundowning? Yeah, it's like if you have a patient say he's going to the hospital, what is sundowning? Yeah, so the sun's going down, they're in an unfamiliar environment, they get very confused, they get very irritable sometimes, they can become aggressive potentially. It's very unpleasant for them, it can be really unpleasant for family. And again, imagine if you just started them on a beta blocker to help manage their blood pressure in the hospital, guess what? That could be exacerbating that. It could be the cause for it, or it could just be kind of helping things along. And so this is why it's really difficult to determine kind of what the primary cause for that dementia or that worsening mental status is. Okay. Other things, elevated triglycerides you may see potentially as well. Again, be wary of that with your patients who have hyperlipidemia. Okay, so in terms of drug interactions, most of the time you're going to find that these are going to be more pharmacodynamic, meaning there's synergy with other antihypertensive agents here. So for instance, if you're adding beta blocker on top of a non-dihydropyridine, like verapamil or diltiazem, what would you expect to see? Decreased contractility, decreased inotropy, see that synergistic kind of drop in cardiac output. So that would be something you want to be careful of. In general, you don't want to combine a beta blocker plus a non-dihydropyridine because you're going to see too much negative effects on the heart, right? However, could I mix a beta blocker with a dihydropyridine? That would actually be appropriate, right? Because you get the negative cardiac effects from the beta blocker, but then you also get the vasodilatory effects from the dihydropyridine. So that can be pretty synergistic. So that's a combination we'll talk about later on. The drug clonidine, we'll talk about this later on. This is actually going to be an alpha 2. This is actually, should say agonist instead of blocker, so that's incorrect. We'll talk about this drug later on. But again, synergistic effects here with other antihypertensive drugs, you're going to find hypotension is going to be a risk when you're combining these together. Okay. So that's it for the beta blockers. Any questions on that? Yeah, it's going to be an alpha 2 agonist. We'll talk about that a little bit later on, so that'll be more clear, and I'll correct the slide. So next we're going to look at vascular smooth muscle relaxants and alpha blockers. So normally when you're looking at an alpha 1 receptor, it gets activated by what substances? Epinephrine, norepinephrine, right? Dopamine, potentially. Right, so if you block those alpha receptors, what happens? Get that smooth muscle relaxation, you get vasodilation that happens here. And so most of our drugs are going to be alpha 1 antagonists. You're going to find they're going to be helpful to relax those vessels, dilate them out, and you're going to see a reduction in TPR. You can see some of these this dilation of precapillary arterioles. And however, just like what we saw with the dihydropyridines, what happens to heart rate? Goes up as a response to that, right? So again, if you have a patient with angina or previous MI, this might be a problem because if you're increasing oxygen demand by the heart, not great. So you're going to find that alpha blockers tend to be good adjunctive agents. They tend to be good to add on for management of blood pressure. However, they're not great by themselves. And the reason for that is because you end up seeing a lot of reflex mechanisms, right? So again, if the kidneys are detecting low pressure, if the baroreceptors are detecting low pressure, you're going to have a lot of reflex mechanisms that kick in. The sympathetic nervous system is going to be ramped up. You're going to find that the renin-angiotensin system gets ramped up, such that they're not really great as long-term antihypertensive agents. However, you need to add them onto something else in order to get that benefit there. So the first one we have here is prazosin. Some people will say prazosin, I just say prazosin. This is going to be a selective alpha 1 antagonist. And again, what you end up seeing here is that it can be useful in addition to something like a diuretic, or this plus a beta blocker can be useful in terms of getting the blood pressure down. Actually has some evidence for helping out with cholesterol as well, so it could be kind of an ancillary benefit, but wouldn't primarily be used for that purpose. The side effects are really big with this one as well. You don't want to use these in elderly patients, and it's mainly due to the orthostasis that you can see here, right? Because again, normally when you're going from a sitting to a standing position, what is happening with your blood vessels typically? You want to make sure you're perfusing the head, so typically you can see vasoconstriction, right? Because again, it's part of that response to make sure that you're getting enough blood flow to the head. However, if your vessels are dilated and they're wide open, you're not going to be able to have that same response, such that they're going to stand up, they're going to get dizzy, they're going to wobble, and they're going to fall, right? So that's a big thing you're going to see with a lot of those patients in avoiding alpha 1 blockers for the most part, right? It could be useful if you're adding it on, or if you start really kind of low dose and titrate up, but that's something you want to be aware of. You see that reflex tachycardia, as we mentioned, which could be problematic for patients who have issues of oxygen demand or supply on the heart side of things, so just be aware of that. However, this is interesting. You do get kind of a balance between vasodilating the arteries and the veins, which was different from the dihydropyridines we talked about. So it will have effects both on preload and afterload, as it turns out, which can be somewhat useful in some cases. But because of the reflex mechanisms of increasing renin, increasing sodium and water retention, you're going to find that ultimately them by themselves as an antihypertensive is going to be very limited in utility. Good as an add-on, but not good by itself. And then obviously sexual dysfunction is going to be a big one with this, because again, if you're dilating the vessels, you may not be able to regulate blood flow to the genitalia very well, unless you can see erectile dysfunction as a result of that. Some other things we can see here in terms of interactions, obviously NSAIDs, as we mentioned, tend to decrease the effects of our antihypertensives. And why is that? So it has to do with the prostaglandins, right? And specifically where? The afferent or efferent? Or the afferent arteriole, right? So again, it's going to constrict that because you get rid of those prostaglandins. Normally those are vasodilatory. It'll get rid of that, clamp down the afferent arteriole, and that does what to GFR? Decreases it, and then what do the kidneys do to respond to that? increase the RAS system, right? So again, this is why you're going to see that the NSAIDs tend to blunt the antihypertensive response here, mainly due to its mechanisms on the afferent arterial, okay? Beta blockers, if you were to add that on, again, you can enhance that postural hypotension, so it can increase risk for dizziness and falls. And then just be careful with patients, heart failure, renal failure, they tend to be a little bit more sensitive to these effects as well. We have a couple other ones, so trazocin and doxazosin. Those you can kind of consider to be working just like prazosin for the most part. Again, usually used for as an antihypertensive effects. But actually, another interesting thing we can use it for is for benign prostatic hyperplasia. So what is that? Yeah, so you have an enlargement of the prostate. What problems does that cause? Constriction around the ureter, right? And then what does that do to urine flow? It impedes it, right? So for male or female patients? Just double checking, right? I want to make sure everyone's got their anatomy down. So for your male patients, right, so over time, due to the effects of testosterone and DHT, you're going to find the prostate gets bigger. Another important thing to consider there as well is that alpha-1 receptors are going to be located on the prostate additionally, and when those are activated, they cause smooth muscle constriction there as well, just like it does in the vessels. So by giving an alpha blocker, you can actually cause the prostate to relax, and that can actually help out with urine flow for those patients there. So a lot of the drugs used for our benign prostatic hyperplasia tend to be alpha blockers. There's going to be also some ones that block the effects of testosterone, but we'll talk about those in urology later on. So for instance, tamsulosin or Flomax, when you just look at the brand name, you know exactly what it's for, right? Yeah, maximum flow, right? So again, it's trying to relax that constriction around the ureter such that you can get better urine flow, unless you don't have that kind of start and stop kind of thing. You get better bladder emptying, things like that. You guys ever watch like those fake commercials like on SNL? Sometimes we'll have those. There was one like years ago where they were like doing like a fake ad for a BPH medication, and they were like showing two guys like watering their lawn, and one of them had this like really bad hose, and it was just like all kinked up, and it wasn't really doing anything. And he looked over at the other guy, and he had this like massive spray everywhere, and I was like, okay, that's like Flomax, right? That's how that drugs work. So anyway, but this one's actually kind of nice because it's a very specific for a subtype of alpha-1 receptor, it's alpha-1A. And the nice benefit here is that it will still get the effects on the prostate, but actually will help have less effects on the vasculature. So that's one way we can kind of get around the issue and not induce hypotension in our patients, but still be able to treat their BPH. So just kind of give you an idea that some of the things you can see in terms of being very selective for one particular subtype of a receptor and how you can mitigate some of those other side effects. Okay, we'll talk a lot more about Flomax and alpha blockers in urology next semester. So next we have our central sympatholytics. What do you think these drugs do? It's not so easy, calcium channel blocker, right? Yeah, they decrease sympathetic function, right? So it's sympatholytic, so they're stopping sympathetic function. So basically from the brain down, now they're shutting down things like norepinephrine and epinephrine release. So everything else we've looked at is working directly either on the vessels or on the heart. This is going to be working from the CNS down, right? So this is where we're going to find that either by stimulating alpha-2 receptors, right? So we're going to be stimulating those. These are what we call autoreceptors. You familiar with the term autoreceptor? You're fine.
Do they activate themselves, kind of? Or?
Yes, they do, right? And so the reason for those is that it's part of that negative feedback loop, right? So just like when your body detects we have enough thyroxine, or T3 around, what does it do to TSH levels? It decreases because we have enough around. We don't need the extra stimulation. Same thing happens with a lot of the neurons, where if you're releasing enough norepinephrine and you have enough there in the synapse, by activating those alpha-2 receptors, it says, hey, we have enough here. Let's go ahead and shut down further release. We have drugs that specifically activate those receptors to help shut that release down. So even though they wouldn't normally be activated, we're activating it for them. So by doing that, we're going to find that you have decreased epinephrine, norepinephrine release there. And what do you think it does to blood pressure? So if I'm releasing less norepinephrine, less alpha-1 activation, should see low blood pressure, right? What happens to heart rate? Decrease that as well, right? So again, overall, you're going to see this nice balance effect between both heart rate and the blood pressure there. Also, there's a lot of other effects you can see here, which is interesting. So it's going to be working on other sites in the brain. Actually, the drugs in this category here, clonidine is the one we're going to focus most on, actually has some good effects, almost like opioid sparing effects. And actually, we use this very frequently in our surgical patients. So if you go work surgery, you might see this, where by using epidurals, we actually will put clonidine into the epidurals and actually help to kind of reduce the number of opioids the patient has to receive, which is always a good thing, right? Fewer opioids is always better. And so you can use these to actually help with pain relief. We can use this for some other purposes as well that we'll see. But again, think about it. If you're shutting down the sympathetic nervous system from the CNS down, what do you also think that does to overall level of arousal in the patient? It'll be decreased as well, right? So sedation is going to be one of the big side effects you see with that. So if you have a patient who comes in and they're bradycardic, hypotensive, sedated, now the sedation could be due to low blood pressure, but also could be related to the fact that you have a central sympatholytic that's working here. And so, like I mentioned, did I talk about the kid who swallowed a patch? Little brother fed a patch to him? Probably mentioned that story, but those who don't remember. One time I had a 10-month-old that came in, and it was very sedate, very lethargic, blood pressure and heart rate were kind of marginal. And so we were trying to figure out, thought that maybe a drug was involved. And so I was interviewing the parents on, say, hey, what medications are in the house? And he gets a 10-month-old, so he's mobile, but not climbing up on stuff just yet. And the dad was like, oh, I'm on a clonidine patch. And I said, okay, was there any chance that the kid could have gotten the patch potentially, got it out of the garbage or something like that? And he goes, no way that could have happened, impossible. I said, okay, well, are there any siblings in the house? And he said, yeah, he's got like a 2-year-old brother. And so I said, okay, he might have gotten the patch out of the trash and fed it to the baby brother. And then, sure enough, we treated it as a clonidine ingestion, and guess what? The kid did in a couple of days. Pooped out a patch, right? So again, it's one of those things where you always have to kind of get an idea of what's going on in the environment. It could not just be the parents being lackadaisical about disposing of meds, but sometimes the siblings can be at play here, right? Sometimes they just want to be the only child, so they said, I'm going to get rid of this other one. I'm just kidding. Usually not thinking that maliciously. But anyway, as you might imagine, clonidine here working centrally, it's going to be able to shut down these mediators here such that you're going to see less norepinephrine release on the blood vessels, right? Also, you're going to see less activity on the vagus nerve, so overall cardiac output is also going to be going down as well, right? So slowing down the heart rate, decreasing blood pressure, get a nice, very balanced effect from that standpoint. Now, as I mentioned, TPR is going down, heart rate's going down, cardiac output's going down. This can be a decent alternative if a patient maybe is a bad candidate for other antihypertensives. Some patients may do really well on something like clonidine. So as I mentioned, decreased TPR with a modest decrease in cardiac output is great. This actually is independent of age, race, and gender as well. It kind of works for everyone. You'll find that certain drugs work better in black populations, certain drugs work better in elderly populations. This kind of works in everyone for the most part, and can be used as monotherapy. Now, note here that you do not want to abruptly withdraw clonidine, because you can see sort of a rebound effect, right? You see a rebound increase in heart rate and blood pressure, and that can induce things like MI in some at-risk patients. Because think about it, if you're not activating alpha and beta receptors enough, what do they do in response to that? They upregulate, right? So if you take that away, all of a sudden that's where you can run into problems. So as I mentioned, sedation is going to be one of the biggest side effects you're going to see with these. Most common thing you're running into, which makes sense because you're kind of slowing down the brain overall. You see dry mouth and sexual dysfunction, and just be very careful because, again, if you're thinking about doses of medications, propranolol may be dosing like, say 100 milligrams, metoprolol 25, 50 milligrams. This is dosing 0.1 milligram, 0.2, so it's a very potent agent. And by having small changes in dose, you can see big effects on your patient there. So one thing you want to definitely start low and titrate slowly for your patients. So as I mentioned, clonidine is probably the most common one. Nowadays, we actually see clonidine, I see this used a lot in pediatrics, not for hypertension. Does anyone know what I see this used for? A chill pill? Absolutely. Actually, that is 100% correct, right? So if you have a kid who has ADHD, this is a medication that can be sometimes used. Now, that's interesting because if you think about it, what's the kind of the standard treatment for ADHD? You give them crystal meth, right? Not crystal meth, but you give them methamphetamines, right? And basically you give them a stimulant. However, this appears like it's a chill pill, right? Kind of slows things down a little bit. So sometimes you'll see kids who are on, say, for instance, an amphetamine during the daytime, and then sometimes they'll be on clonidine at night to kind of help bring them back down a little bit. Again, I don't like to treat one side effect of a drug with another drug, but sometimes that's how it works. Some kids just do really well on clonidine by itself, right? So it just depends. There's a few other drugs we'll talk about being used similar to this here. Clonidine, most commonly, though, you're going to see in adult patients being used mostly for blood pressure management. Other things you can find, it helps decrease AVP or ADH secretion, which can be helpful getting rid of some of that extra water, so it can help with fluid management there. But you will see the reflux mechanism, right? So you may see some reflex sort of increase in sodium reabsorption. So occasionally by giving this with a diuretic, that can help to enhance the effects quite a bit from a hypertensive standpoint, okay? And as I mentioned with the analgesic activity, actually one of the drugs that we'll give to patients, so say you have a mother who is abusing opioids throughout her pregnancy and then give birth, guess what? That baby has been exposed to those opioids the whole time too. When they start to withdraw, what do you call that? Anyone know? Neonatal abstinence syndrome. They get very cranky and they don't feed very well and they can't regulate their temperature very well because they're withdrawing from opioids, just like adult patients do. And we give them clonidine because if they're in that really hypersympathetic state, we'll give them clonidine that helps to shut some of that down. So if you ever see that, like little kids on, like infants on like methadone and clonidine, that's what we're using it for, is to try to help blunt that withdrawal. So, as I mentioned, the withdrawal effects are really big things to be noteful, or to note here. You want to make sure you titrate slowly off of them if they're on it chronically. And again, you can't see that impotence, orthostatic hypotension, or bradycardia based off the mechanism. That makes pretty good sense. Another drug that fits in the same category is going to be guanfacine. So this is another one that you'll see occasionally used for ADHD, depending on the indication. They may go with this, they may go with clonidine, just depends on the patient there. It's a little less potent, but it's going to be a little bit more selective here for these alpha-2 receptors. And so what you end up seeing is less sedation associated with this. You also see a little bit less of that withdrawal phenomenon. So it's okay for a patient to go off of this cold turkey more so than it would be for clonidine. Yes, that is one benefit of guanfacine. Okay, and then getting into our direct vasodilators. So we talked about alpha blockers, which are preventing vasoconstriction. These are actually drugs that go in and directly dilate the vessels themselves. So overall, you're going to find that most of them are going to be focusing on an arteriolar dilation. So you're going to see decreases in TPR. However, what would you see a reflex increase in? Heart rate, cardiac output, right? So again, you're going to find that also these are not great by themselves in terms of antihypertensives, because you do get a lot of that strong reflex response in terms of fluid retention, increasing your renin and whatnot. And so occasionally you may find that these are good as an add-on agent, but typically not used by themselves for the most part, unless they're used for like really acute blood pressure management, like I'll mention in a moment. And you can see that tachyphylaxis. And what does that mean? We talked about this before. So remember, even if you keep increasing the dose of the drug, you're not going to see a whole lot of additional benefit, right? So because of those reflex mechanisms, the renin is going to be so upregulated, your ADH is going to be upregulated, all those different things are going to cause it to lose its effectiveness. So even if I keep jumping up the dose, it doesn't do a whole lot of additional benefit. Okay. So 3 we'll talk about here includes hydralazine, minoxidil, and nitroprusside. Now most people are not familiar with minoxidil being used as an antihypertensive. What do we normally use that for? No? Yeah, it's Rogaine, essentially, right? So we'll talk about why we can use that for there in a little bit. So again, looking at the effects here, these are mainly going to be arterial vasodilators. So you're going to see low blood pressure, right? You can see tachycardia as a result of that. And then again, the stronger the effects on the blood vessels, the stronger that reflex response is going to be here as well. So you can see a lot more sodium retention associated with that. So again, we can use this for chronic hypertension. Usually it's going to be an add-on agent, either to like a diuretic or a beta blocker. However, in some cases you may have to use it as triple therapy if you need some additional benefit and an additional mechanism to work through that. And then more commonly, I use this on the in-hospital side, where we use it for hypertensive crises or urgencies, where we can give an IV agent to directly lower the blood pressure to prevent things like stroke from occurring or MI, things like that. So hydralazine is the first one here, called a presaline. This is another one that's used frequently IV. It's like a PRN. If a blood pressure is too high, the nurse will have orders to go ahead and give this once the systolic gets so high to use this to help manage the blood pressure. Basically, how it's working, and it's not fully clear, but we think it increases cyclic GMP and it increases nitric oxide. And what does that do to the arterial smooth muscle? Usually dilates it, right? So it's going to cause some dilation here. May have some effects on renal prostaglandins, but this is the big thing here. May influence some calcium movements, but just think about that nitric oxide pathway being activated here with the hydralazine. Now, this is important in terms of how it gets metabolized. It goes to this N-acetylation in the liver here. Now, this is important because you have some patients who are going to be fast acetylators, and some patients who are going to be slow acetylators. So which type of patients do you think hydralazine would work better in from an antihypertensive standpoint? Slow or fast acetylators? Slow. Okay, so slow acetylators. Why? If they're not acetylating as quickly, the drug stays active for longer. Guess what? Half-life extends, duration of action extends. It'll work, stick around for longer, right? What does that also put the patient at risk for? Toxicity from the drug, right? Exactly. So slow acetylators may get better benefits out of this, but they can also be at more risk for toxicity. Versus your fast acetylators, they may require higher doses of the medication here. Now, there's not a routine test that we do to see if a patient's a fast or slow acetylator, so sometimes you just have to go with trial and error to see how they respond to it. So just be aware of that. And again, some of the side effects, because you're directly dilating the arteries, you're going to see the headache, the dizziness, and the flushing of the skin predominantly. Now, this is an interesting thing here. This is unique to hydralazine, and this is going to be more common in slow accelerators. You find it more common in females and Caucasians. You can actually induce this lupus-like syndrome in patients taking hydralazine. So basically, they have sort of an autoimmune sort of reaction with the medication, and so you can think about like the butterfly rash can appear here. You can see other manifestations of this as well, but just know that hydralazine is kind of unique in causing that lupus-like syndrome for those patients, and who it might be more commonly caused in. Okay, so people would be contraindicated in, what do you think, coronary artery disease? Think about the increased uptake in cardiac output, right? Remember, by causing that direct vasodilation, it's going to be increasing cardiac output as a response to that. That can exacerbate someone's coronary artery disease. They have angina, things like that. And again, if they have any kind of ischemia, be very wary of using hydralazine in those patients there. Also, as I mentioned, anytime you turn a patient's urine or stool into a different color, you want to be noteful of that. This will turn the feces black, right? Which is concerning because what do you normally think of? An upper GI bleeds, right? So anyone know what else can turn your feces black? Iron's another common one that can do that as well. Yep. Okay, so anyway, minoxidil is a very old drug, and originally we tried using it as an antihypertensive, and it was good at doing that for a short period of time, but that renin braking sort of system there, it really kind of prevented it from being all that great. This one has a different mechanism than stimulating nitric oxide specifically. It actually can open up these potassium channels, and if you remember, by letting more potassium out of the cell, it actually helps to hyperpolarize it and prevents action potentials from causing activation, right? So by doing that, you're going to see that smooth muscle relaxation, very good at what it does, but again, you're going to find that it will cause a lot of other rebound effects, as we're going to see there. Actually, the reason why we tried using it as antihypertensive, realized it wasn't that great of a drug. However, there was another side effect we ended up seeing with this. You know what that was? What do you call that? The hypertrichosis, right? So hypertrichosis or hair growth can happen here. It doesn't necessarily cause abnormal hair growth, like it doesn't like give females a mustache or something like that. However, the hair that is growing there can be stimulated. So now, how do we use it normally? Use it topically, right? So you can actually apply it topically to the scalp, and that will help to increase blood flow locally to the areas and hopefully help those little follicles grow back out, right? So those are how we typically use this. I'll tell you, I had one patient who he was an alcoholic and unfortunately was not able to find any alcohol at the time. So I guess he was wandering around a Walgreens at the time, and he was down the hair care section, and he saw this thing of Rogaine, and he was looking at the label, and he saw that it was like very high alcohol content. And so why do you think it had high alcohol content? Maybe that could be one thing, but it's usually dissoluble as a drug to actually get it into solution. But he saw this and he said, well, here's some alcohol. I'm going to go ahead and just drink that. So he had an entire bottle of Rogaine. So how do you think he presented? Very hairy? No, unfortunately, that would be pretty funny if you came in like Chewbacca, like walking to. Doesn't work that fast. I wish it did, right? Otherwise, it'd probably be very popular amongst gentlemen. However, what happened was he came in profoundly hypotensive and tachycardic because he had so much Rogaine in the system. He was causing so much vasodilation because all those little blood vessels, all the smooth muscle there was hyperpolarized. It could not cause that constriction to occur there. So really tachycardic, really hypotensive. I think by the end of it, we ended up having him on 3 or 4 different drugs to try to get the blood pressure back up before we finally found one drug in particular that worked for him. And I think it was like 4 or 5 days he ended up being in the ICU on pressor therapy in order to keep his blood pressure under control. I think we published a case report out of that, so if you're ever curious, you can try looking that up. I think my name's on there. But very kind of interesting. Just this guy had no idea what he was drinking. He just took the whole thing and then ended up in the ICU for like a week. So pretty interesting kind of case there. Anywho, you can see arrhythmias though. Anytime you're kind of mucking around with potassium efflux, you can see risk for things like ventricular arrhythmia. So it would be one thing to note here. Fortunately, that patient did not have any arrhythmias other than just sinus tachycardia from that vasodilation. As I mentioned, the hypertrichosis, you can see that on the face, the back, the arms, the legs. Again, if you're taking it systemically, you're going to see systemic effects versus if I just rub it on the scalp, you're more likely to see the effects just right there, which is good. Okay. Also be aware that you can see dermal absorption of that. So if you're not washing your hands appropriately, you can see some systemic absorption. You could see potentially headache associated with that due to some of that vasodilation. You could see a little bit of dizziness. So again, we either tell them to use gloves or at least wash their hands really good afterwards. Now, nitroprusside is an interesting one. This is actually one nitric oxide molecule, and it's attached to 5 cyanide molecules to iron. So the nitric oxide itself will activate CGMP, which causes vasodilation itself and decreases that kind of the internalization of calcium. So that's what relaxes that smooth muscle there. What kind of effects do you think you could see? Is there any inherent problems with this kind of medication you could run into? It includes cyanide, right? That's not great, right? Normally we keep cyanide in our teeth so we can crunch down on it and for a spy maybe. I'm not familiar with that trope. Anyway, so yeah, so this is going to be a kind of a unique toxicity you see with nitroprusside. However, we still use it in patients all the time. It's a very effective agent to help manage blood pressure. This is only going to be like given via IV, usually like in the ICUs to help manage that blood pressure. It has good effects on both the veins and the arteries, which is handy. As I mentioned, it's the toxic metabolites we worry about. Now, your body actually produces a small amounts of cyanide all the time anyway, but we have the liver is able to detoxify. It's able to complex it with something else and get rid of it, usually a sulfation sort of pathway here. However, we can overwhelm that pretty quickly, and so what we actually do is we give nitroprusside with something else called sodium thiosulfate, and it actually helps to limit that cyanide toxicity, such that you get the blood pressure benefits, but you also prevent any kind of cyanide issues here. And what you can see with cyanide is it actually can cause a lot of trembling, vomiting, convulsions, can lead to metabolic acidosis. Anyone know how cyanide works? It actually prevents the mitochondria from utilizing oxygen to produce ATP, right? So it basically kind of switches your body over into this anaerobic metabolism. Again, I can probably talk about it for an hour. I'm not going to bore you with that. I'll just bore you with this stuff. But anyway, so we give sodium thiosulfate along with nitroprusside to prevent that toxicity from occurring, okay? And in fact, if you have poor kidney function on top of that, you can actually develop the metabolite here. You can actually build up high levels of that, and that can lead to things like tinnitus, muscle spasm, etc. So just be aware that organ function is really important to monitor for those patients. Okay, so those are all the antihypertensive drugs, or at least most of them. At least all of them I'm going to cover. So the question is, how do we use these medications, right? So what's the right drug to go with? We have a couple dozen drugs we just learned about. How do I know which one to go with? Very frequently, you're going to find that other disease states will dictate which drugs you're going to go with. So if they have a history of MI, if they have angina, if they have diabetes, if they have all these different things, will kind of lead you to picking one drug or another off of that. But where do we find our guidelines? Anyone know? It's on the slide. The JNC8, and we also have the AHA guidelines that help us out with this. Okay. Now, again, I'm not going to get too in the nitty-gritty here, but a lot of the questions that I'll be asking on the test could be things like, hey, you have this kind of patient who's hypertensive. Which one, they have these allergies, they have, this disease state. Which one of these medications would be best suited for them as initial antihypertensive therapy, right? It's your job to be able to kind of identify kind of things in the patient that would maybe preclude them from receiving one kind of drug or maybe make them a good candidate for a different type. So as an example, like a diabetic patient, what kind of antihypertensive could they benefit from? An ACE inhibitor, why? Kidney protective, right? Helps to hold their, helps to keep their kidney function higher for longer, right? Doesn't reverse anything, but slows it down. So again, those are the kind of things I want you to kind of key in on, right? Or for instance, if I have, say, an asthmatic patient, which one of these would be relatively contraindicated? And if I had a non-selective beta blocker on there, you say, well, that would be a relative contraindication, right? So we don't like to ask negative questions, and actually I'll never put a negative question on a test. If I do, you can come publicly shame me. But I may ask you, which one of these is contraindicated? It sounds like a negative question, but it's kind of not, maybe? I don't know. I think those are fair, though. So anywho, in general, though, a lot of our goals is to get them down underneath 130/80 or so, and that includes patients with diabetes, chronic kidney disease. Again, lower is not always better, but usually around this range is going to be preferable. In terms of medications you're going to be using, so sort of initial treatment strategies, patients who are Black, with or without diabetes, generally benefit most from a thiazide diuretic. That includes like your hydrochlorothiazide, indapamide, chlorthalidone. I think indapamide and chlorthalidone have a little bit more evidence for kind of better initial management. Or they could use a calcium channel blocker. Okay. Now again, don't specify between dihydropyridine versus non-dihydropyridine, most of the time you're probably going to go non-dihydropyridine. Why do you think that is? I'm sorry, you're going to go dihydropyridine. What do you think that would be? Because they don't need the negative cardiac effects. If I'm just looking to get their blood pressure under control, then I want to focus just on the vessels there. So using something like amlodipine or nifedipine, that's going to be a better option for those patients there. So in general, we can go with that. But if they have a history of AFib, well, then maybe something like, verapamil diltiazem would be reasonable for that patient. Okay, again, you have to take all those different factors into account here. In non-black population, with or without diabetes, again, start off either with a thiazide, usually a dihydropyridine calcium channel blocker, ACE inhibitor, or ARB. Okay. Note if they have chronic kidney disease, we're also going to look to use either an ARB or an ACE inhibitor, mainly due to the kidney protective sort of effects we see with that. Okay. Now, note what would lead me to choose an ARB versus an ACE inhibitor. Yeah, so if they have a history of a bad reaction to an ACE inhibitor, maybe that would kind of lead you to one, or if they're started on an ACE inhibitor and they had that chronic cough, that could be one thing to consider switching them over. But again, initially, it's going to be whatever's cheaper, whatever the patient can get a hold of. That's going to be the big thing that differentiates those two. Okay. Now, again, you're going to give them some time to see how the drug is working for them. Oftentimes, you're not necessarily switching them based off the fact that the drug wasn't working, but oftentimes it's because of the side effects they're experiencing. So they come in and they're having the hacky cough, and they're like, my wife's about to kick me out of the house. What can you switch me to? You'd be able to come up with a couple different options there, right? So you can say, okay, well, the ACE inhibitor had you under control, your blood pressure was looking good, but you had that cough, let's just go with an ARB, right? Or maybe the ACE inhibitor really wasn't doing it for them, maybe switch them over to another class entirely. Let's try amlodipine instead, right? So those are things you can consider. Again, if they're not in goal within a month or so, then you can either try increasing the dose, try switching over to another drug altogether, or potentially add on a drug, right? So again, think about kind of rational combinations of things, like would I want to do, say for instance, valsartan plus lisinopril? Does that make sense? Valsartan is what kind of drug? It's an ARB. Lisinopril is a ACE inhibitor. So would combining those two make a lot of sense right off the bat? No. What if I did like chlorthalidone plus lisinopril? Chlorthalidone is what kind of drug? It's a thiazide diuretic plus an ACE inhibitor. That would make good sense, right? Because you're attacking it from two different mechanisms. So you're looking for synergy there. Now, note when I say here diuretics, I'm specifically saying thiazide diuretics, right? Loops are not good for long-term management of blood pressure. Why is that? Again, there's that reflex mechanism that leads them to not be all that effective, right? They're good for getting rid of that fluid, but they're not really good for that chronic antihypertensive effect. The thiazides are better because they help with that waterlogging of the vessels. They help kind of shrink the vessel diameter. They do all those things. So that's why thiazides are really the things you're going with here, right? But if you have a patient who's edematous, they have CHF, give them a loop diuretic. That'll get rid of that fluid, but it's not going to be the thing we're using for their blood pressure. Okay, that makes sense? Those are the kind of things you want to look for. And again, this may seem very non-specific, but that's because when we get into all the other disease states, you're going to see that, oh yeah, well, if they have a history of angina, if they have a history of MI, that's going to dictate what they're going to be getting based off of that. So that's usually where you're going to be deciding which agents to go with. So for instance, they have a previous MI, then they're going to need to be on an ACE inhibitor, they're going to need to be on a beta blocker, they're going to need to be on aspirin, they're going to need to be on a statin. There's a whole litany of drugs that they're going to have to be on because of the mortality benefits and the evidence-based medicine we have to dictate that. Okay, but we'll get into more of that a little bit later on. Any questions on that section? Took me a lot longer to get through than I expected. So, obviously I will modify the test as needed to account for what we cover. So I'm not just going to give you the whole PowerPoint and say, go read this, and then be tested on Monday. That would be exceptionally rude of me, right? My reviews would be terrible, and that's really what we're here for. Good reviews from you, on me, right? It's the only validation I get in life. Just kidding. Anyway, so I'm not going to get started on the next thing just yet. Where's the next one? So I posted this up. I'm going to decide how to approach things. Depending on how things go, I might try to do some of this section and then do a review. When's the next time we meet? Thursday? Tomorrow? Yeah, so tomorrow we'll decide how to approach this, and I'll have to modify the test probably to account for that. So we might go over like maybe half of this and then do the review, but I'll make that executive decision at that time. Decide what to do. I know if I ask you what you want to do, I'll get a very different answer than what I want to do, so I'm just not going to ask in the first place. So let's go ahead and cut it there. Let me see if there's any questions. Ooh, there's a bunch of questions. Fantastic. Okay, that one's already answered. We talked about that one. What is ISA? That is, oh, I got two of these. Is that intrinsic sympathomimetic activity. It's where a beta blocker could actually stimulate some of those beta receptors, which may not be great if you have a patient with angina, may not be great for patients you don't want that extra stimulation on the heart, but just be aware that that's what that stands for. Okay. Clinically, this doesn't come up as much as you might think. Typically find that most beta blockers tend to work fairly well equally to one another. There's some indications that where like propranolol is really going to be a preferred agent, metoprolol, etc. But this one is that's what that stands for essentially. Okay, so let's say you have a young patient with ADHD taking amphetamine chronically and is causing tachycardia and palpitations. Would you give these patient a chronic beta blocker to help that? What do you think? So they're getting palpitations from their amphetamine. Would I want to add on another drug to fix that, or what else could I do? Probably try either modifying the dose of the amphetamine they're currently on, or I might try switching over to a different agent, maybe that will work a little bit better. There's certainly other options than just amphetamines, which we'll talk much more about in the psych section next semester. But you know, there are non-amphetamine based products. There's things like norepinephrine reuptake inhibitors that you can use there. You know, sometimes patients, if they're still kind of wired towards the end of the day, that's where clonidine can be useful in the evening to help kind of control that. But generally, I don't want to add on another drug just to specifically treat those effects. Because again, what do you think is the side effect of a beta blocker that may impair the ADHD meds? Cause sedation, right? Because again, you can kind of, especially if you have like more of a lipid-soluble agent, cause sedation, and that's what you're trying to potentially, you know, it could be counterproductive with the amphetamine that you're giving them to keep them more awake and more focused on what they're trying to study, right? So hopefully that wasn't for personal use. So I'm not giving out medical advice here, right? Go see your doctors. Would hydralazine be contraindicated in patients with lupus since it can cause a lupus syndrome side effect? I would be very cautious in using it in those patients. It could be exacerbated there because, again, what kind of patients get lupus? Like white females you kind of think about. And so, again, those are the type of people that were more likely to have the lupus-like rash. So I kind of think about that as something I would probably not want to push. I would try to find a different agent to control that blood pressure. Let's see. Why is it contraindicated to use a beta blocker in someone who uses cocaine? Oh boy, I could talk about this for a while. Okay, how does cocaine work? Does anyone know? So it does vasoconstrict. How does it do that though? So what cocaine does is it stimulates your neurons to release catecholamines, right? That includes norepinephrine, that includes a little bit of epinephrine, but it also includes dopamine, right? And dopamine is really important for what pathway? The reward pathway, right? So you have a big juicy hamburger, you have sex, you drink alcohol, any kind of drugs, like it stimulates that dopamine pathway. It says, ooh, that was really good, I want some more of that, right? That's why people get addicted to cocaine. But it also will release norepinephrine, and that's what causes vasoconstriction, leading to hypertension. It's what causes tachycardia, because that effects on the heart. It's kind of like the opposite of clonidine, right? Clonidine shut down all that release of norepinephrine. This is directly stimulating the sympathetic nervous system, okay? So the question is, well, why would you want to be careful in using a beta blocker in a patient with cocaine? So cocaine's stimulating both alpha-1 and beta-1 and beta-2 effects, right? So if I give someone a beta blocker, let's say I give them a non-specific beta blocker, I'm going to block beta-1, so I'll slow down the heart rate. However, if I block beta-2 on those vessels, now what happens? Because beta-2, when it's stimulated, normally does what? It causes dilation. It normally relaxes that, right? So I have the alpha that's trying to squeeze down on it, I have the beta-2 relaxing. What happens if I take away that beta-2 effect? Unopposed alpha constriction, right? That's the thing you'll hear about when you think about beta blockers and cocaine usage. Unopposed alpha, and that can lead to stroke, lead to MI. Now, is there a ton of clinical evidence we have that shows that this happens much? You know, it's kind of one of those medical dogma things you hear about so much, you just never want to be the person to do it, because you don't want to be like that person. Like, it's like having your name up on the wall for doing something. It's like, oh yeah, that's that memorial award for that person because they're the dummy that gave a beta blocker to a cocaine intoxicated patient. Frequently what we'll do instead is you can use other medications to help kind of control a lot of those sympathomimetic effects. So we can give things like benzodiazepines to kind of calm them down. We may use a beta blocker plus a vasodilator at the same time, and that can get a better balanced effect there. So again, not pertinent to our talks right now, but again, that's something that I'm interested in. Okay, let's see. Any other questions? I think that's it. Let me refresh here. Do you all have any questions? No? All right, well, I'll see you guys tomorrow.